For the next session, the topic of discussion is approach to incidental SOL in pancreas. May I please invite upon stage the chairpersons for this session, Dr. Sunil Jain, Senior Gastroenterologist and Interventional Endoscopist from Indore, Dr. Ravindra Kale, Senior Gastroenterologist from Indore, and Dr. Saurabh Dubey, Consultant Gastrointestinal Surgeon from Bhopal.
Good morning. Our next talk is on incidental pancreatic SOL, what to do, and it will be delivered by Professor Pramod Garg. He is in AIMS, Executive Director, Associate Dean, and everyone of the audience knows him.
Good afternoon. At the outset, I'd like to thank Dr. Sanjay Kumar, the organizing chairman, for this kind invitation. I'm going to talk about an approach to an incidental space-occupying lesion in the pancreas, also known as incidentaloma of the pancreas. Now, by definition, a lesion like this should be picked up on imaging, which is done either as a routine investigations, which is kind of fashionable nowadays, or the investigation has been done for some other indication and the patient is asymptomatic, at least as far as that lesion is concerned. And we have to also differentiate space occupying from diffusely enlarged pancreas. For example, you see here it's a diffusely enlarged pancreas, and here you see there is a space occupying lesion. So that's the difference. Now, in general, if you have a space occupying lesion anywhere in the body, particularly in the pancreas, we should take it as neoplastic unless proved otherwise. And the reason for that is that if you miss a neoplastic lesion, you will have more severe consequences if you don't consider it as neoplastic. It is either malignant or benign. If you have a benign lesion, it could be benign neoplastic, but sometimes you do see infectious lesions, but they are very, very uncommon. Another important thing we have to find out when you have a space occupying lesion, whether the lesion is solid or cystic, and this has major implications for the diagnosis, treatment, and prognosis. And third, sometimes you have a solid lesion with cystic degeneration. When we have to approach these patients in whom you have found a space occupying lesion, the important factors to consider to make the diagnosis and also treatment are age of the patient, sex of the patient, comorbid conditions, for example, underlying diabetes, and whether the lesion has been picked up de novo or there is an underlying disease, for example, chronic pancreatitis, or patients has had, say, for example, acute pancreatitis in the past. That has a major bearing on the final diagnosis. And then you characterize the lesion on imaging, which I'll come to subsequently. So there are three common types of lesion. One is pancreatic ductal adenocarcinoma, second is cystic neoplasm, and third is neuroendocrine tumor, about which we had a very nice panel discussion just now. And the other we often see is autoimmune pancreatitis and sometimes infections, but my focus would be on pancreatic ductal adenocarcinoma and cystic neoplasm, because neuroendocrine tumor has been recently discussed. And there are some other rare tumors I'm not going to discuss at all, nor will I ask you to read this. These are primarily histological curiosities which are found on surgically resected specimens. You can't really make a diagnosis on clinical or imaging criteria. Coming to the incidental pancreatic ductal adenocarcinoma, it is rarely incidental because nowhere in the world there is a screening protocol, so it is very difficult to pick up small incidental pancreatic ductal adenocarcinoma. By the time they are picked up, most are symptomatic. Their characteristics are that patient is usually elderly, beyond the age of 60 years, and maybe diabetic. The lesion is solid, and the characteristic finding here is that the duct upstream is dilated. So wherever is the lesion, if you find the duct is dilated, be very, very careful. This patient needs your attention right away. And this is a classic example. If you see here, very subtle dilatation of the distal, in the tail of the pancreas, duct is dilated, and there is a very subtle small lesion here. Take it as ductal adenocarcinoma unless proved otherwise. You can do further test, for example, PET-CT or EUS to confirm it, But generally speaking, FNA is not going to help you because of one reason, that if you do FNA, the sensitivity of FNA is at best 90%. You are going to miss 10% of those patients. And even if it turns out to be benign on surgery, it is okay. You have done a reasonably good surgical procedure. You don't have to worry whether it is benign ultimately. In fact, the patient and the surgeon will be happy that the lesion has turned out to be benign rather than malignant. Overall, if you look at solid pancreatic SOLs diagnosed incidentally, it's about 0.6% according to one series in healthy kidney donors. In a series of about 3,000 patients, people who had undergone PET CT for unrelated causes, about 0.5% had a pancreatic SOL. And this is a very large series, about 40,000 PET CT done for cancer screening in Japan. The incidence of pancreatic ductal adenocarcinoma was only 0.001%, which is somewhat similar to the incidence of pancreatic ductal carcinoma. So it's not very common to have solid lesions on incidental imaging. If you look at the series of resected lesions, that those lesions which have been resected by surgeons, you find that solid lesions are 31 to 65%. So majority of solid lesions are actually resected, and of these, you have about 1/3 ductal adenocarcinoma, and about quarter to 1/3 will be neuroendocrine tumor, and then you have other rare causes. And sometimes focal chronic pancreatitis is also found to have on surgery, which is a mass-forming inflammatory lesion. Now, what is the impact of outcome if you find a lesion on imaging and patient undergoes treatment? So overall tumor resectability is better if you find an incidental lesion versus those who have symptomatic, which is kind of logical. Median survival somewhat better, but you see here in this series, it was only 16 months. The reason for that is a pancreatic ductal adenocarcinoma is a very, very aggressive tumor. And the lymph node involvement was also similar, which is rather surprising. And same for another series of about 1,800 Whipples, they found stage 1, which were kind of picked up incidentally. 34% patients had stage 1 tumor, and the overall 5-year survival was about 50% better than those who had symptomatic disease. This is just an example of a patient came to us, 75-year-old male, incidentally picked up a small lesion in the neck of pancreas. PET CT was done, which confirmed a positive lesion about 1.4 centimeter. We advised surgery. He didn't agree for that, and 2 years later developed unresectable tumor. The reason I'm showing you this particular example is that whenever you have lesion, please discuss with your patient very carefully and say that why it is so important for these patients to undergo surgery, because then you can have kind of a curative resection. The other issue is when you have a underlying chronic pancreatitis, patient comes to you either with symptom or without symptoms, and you do investigations, you find a space occupying lesion there. It is likely to be malignant if there are two things. One, it is idiopathic chronic pancreatitis, and you have a mass lesion, it is likely to be malignant. And second, if there is a new onset of pain for a few months, consider malignancy very strongly. Okay? Now, it is likely to be inflammatory if you have a patient with alcoholic CP who comes in with history of 1 or 2 years of pain. There is diffuse enlargement of the head of pancreas rather than a discrete mass, or you find that the pancreatic duct is coursing through the lesion. So these are the two characteristics on imaging: diffusely enlarged head of pancreas or a duct coursing through the head. It is likely to be inflammatory, and the etiology of CP is alcoholic. This is what has come out from our studies, and this is an example of a patient who had chronic pancreatitis, came with new onset of pain, and was found to have a suspicious lesion in the head of pancreas. You can see here there are calcification and there is a soft tissue mass there. Sometimes difficult to identify what it is. So often in these patients you should do FNA to confirm. But if you are sure about the mass lesion, you don't have to do FNA. You can directly send the patient for surgery. In this particular patient, FNA was done, and also a contrast enhanced EUS was done. This is a video given by my colleague Dr. Sharma Jagannath. He does a lot of these interventional and diagnostic EUS. I'm going to skip PNET because we have discussed this. Now coming to the second variety, that is cystic tumors. So that means the lesion is cystic on appearance on imaging. The incidence actually prevalence seems to be actually fairly high. It varies from 1 to 24%. Now that depends on the kind of imaging that has been done. That also depends on the age of the population where this has been done. But it's fairly common to have on CT or MR a cystic lesion. There are three main types: serous cyst adenoma, mucinous cystic neoplasm, and intraductal papillary mucinous tumor. And these are other things which can confuse you with cystic neoplasm. This is a kind of standard patient, middle-aged lady comes to you with non-specific abdominal pain, no other problem, no antecedent pancreatitis. That's very important. And you find a lesion on the in the tail of the pancreas or distal body, and the diagnosis here is either a cystic neoplasm or pseudocyst. If you have this kind of lesion, only about 2 centimeter lesion, there is nothing inside, it is likely to be a benign mucinous cystic neoplasm. Often the issue is whether it is a pseudocyst following acute pancreatitis or is a cystic neoplasm. The best test to tell you that is the first imaging when the patient had any symptom. If at the time of first imaging, whether you have an ultrasound or a CT or MR, it shows a cystic lesion, it is likely to be a cystic neoplasm. If the first imaging didn't show it and subsequently you find it, it is likely to be a pseudocyst. Very simple, okay? And then of course there are many other features which can be found on CT and MR between pseudocyst and cystic neoplasm. Cyst fluid analysis, I'll come to that, generally not very helpful, but if you do it, you find in cystic neoplasm, primarily you are looking at mucin. If mucin is present, it is either MCN or IPMN and not a pseudocyst. So just a brief description of these three types. Serous cyst adenoma seen in elderly females, 6 and 7 decades of life. More than 50% are asymptomatic. Symptoms include abdominal pain, mass lesion, or sometimes even jaundice. The characteristic imaging findings are it is microcystic, there is no communication with pancreatic duct, and a stellate scar may be seen, which may be calcified also. A classical example of serous cyst adenoma on a CT, and on EUS you find microcystic appearance. Fortunately, these are very slow growing tumor and the potential of malignancy is very low, and they usually do not require surgical resection. You can just follow them up over a period of time. Mucinous cystic neoplasm are seen in middle-aged ladies. Location is generally in the body and tail of pancreas. They may present with pain or diabetes or antecedent or presentation with pancreatitis, but incidentally they are detected in about a quarter of patients. The characteristic features here are macrocystic appearance, no communication with PD. This is very, very important. And on histology, we find ovarian stroma, and the risk of malignancy is about 17% according to one series, but it varies on the type and the size of the lesion. CT and MR are good modalities to differentiate and diagnose mucinous versus non-mucinous, but the overall diagnostic accuracy is around 80% between mucinous and non-mucinous tumors. And therein comes the role of EUS, because most patients with cystic neoplasm will require a diagnostic endoscopic ultrasound, and there you may, I will come to that, you may do a fluid analysis to find if there is a mucin, if there is mucin present, string test is positive, amylase is normal, CA may be high, and this test has come up recently that the glucose content is low, it is likely to be a mucinous tumor with a very high sensitivity. But overall fluid diagnostic accuracy varies from 40 to 60%. So the imaging characteristics are more important. So you have a lady like this, she has a 2 centimeter lesion in the distal body of the pancreas, there is nothing inside. It's a benign MCN, 2 centimeter, asymptomatic, do nothing, just follow up, okay? On the other hand, you may have a patient like this, where the lesion again is not very large, it's about 2 centimeter, not seen very well, but you can see here that there is a intramural nodule here, there are septae here, which are enhancing on CT, and this is a MCN with high risk features, and these patients would require surgery. This is another video given by Soumya done recently of a patient with mucinous cystic neoplasm. You note here multiple thick septae here, and there is a solid looking lesion here. And he did a contrast enhanced EUS. You find this is the lesion, and the lesion lights up. The solid part lights up on contrast. That means we are dealing with a very high risk MCN here, and these patients would require surgical resection. Generally, they are benign, may progress to malignancy, and surveillance is justified in these patients, but less than 3 centimeters benign you should observe. Coming to the third type, that is IPMN, they arise from the duct filled with mucin. They communicate with PD. That's again important differentiating feature, and about 30% may have asymptomatic. Main duct lesions are seen 47 to 75%. They are usually symptomatic. Side branch IPMN are generally asymptomatic, seen about 25 to 39%. The duct is dilated in main duct IPMN, and that is what differentiates between the two tumors. So this is branch duct, this is main duct, and this is a mixed type. Location is usually in the head of pancreas. MRI and EUS again very useful. Sometimes you may see in a main duct IPMN a fish mouth papilla from which you can see mucin coming out. This is a classical example of a branch duct IPMN, about 3 centimeters in size. This is classical example of a main duct IPMN with solid mass inside. And this is what the classical fish mouth appearance is. I have only seen it once, and that's a video I keep showing all the time. And that you have a fish mouth appearance of a papilla, and you can see this mucin coming out. Then it is diagnostic of IPMN. A malignant potential in both MCN and IPN increases with the size of the lesion, and there are many guidelines available. This is the Fukuoka guidelines commonly followed, that you may have worrisome features and you have high risk features, depending on which you can consider surgery. Generally in IPMN, if it is branch duct less than 3 centimeters, no surgery is required. Main duct, malignancy risk is high, and you should advise surgery in these patients. Prognosis generally is good. One word about FNA. Generally, people tend to do FNA, but there are pros and cons of it. Fluid analysis has 60% diagnostic accuracy. You can do molecular markers, but there's a risk of infection and also pancreatitis. And it should be done only when you are not sure if there is a solid lesion within this cyst, and there's a clinical strong doubt of pseudocyst. So these are the 3 main types in summary. So the approach to incidental SOL in the pancreas on imaging, that is CT generally is the first test. You may have either a solid lesion or a cystic lesion. If it is a solid lesion, do an EUS, sometimes FNA, not always. If there's a suspicion of NET, you can do FNA, otherwise generally no. You may or may not do MRI, but solid lesion, generally there is a need for surgery. If it's a cystic lesion, you do MRI for sure, and also you do EUS in almost all cases. And if it's less than 3 centimeters, no worrisome features, benign, follow up. But if you have high risk features, then consider surgery. If you have worrisome features, you may do EUS and FNA. And if it's a more than 3 centimeter lesion with either worrisome or high risk features, these patients require surgery. So I'd like to summarize, ladies and gentlemen, by saying that there is increasing awareness of SOLs in the pancreas because of widely available and routinely practiced CT and MRI in these patients. Solid lesions are uncommon, but more likely to be malignant and requires more often surgical resection. Cystic lesions, either serous cyst adenoma or MCN or IPMN, they are usually benign. EUS is helpful in the diagnosis. Less than 3 centimeters, we follow up and do nothing. More than 3 centimeter, large or symptomatic lesions require surgery. Thank you for kind attention. Happy to take questions.
Pramod, I wanted to ask, see, if you look at all the guidelines, like Fukuoka is there, you have AGA guidelines, and of course, Indian Pancreatic Association, there is one area where they all differ, and that is regarding the surveillance intervals. So what policy you follow if you want to follow these particular patients, or how long will you continue with surveillance in this?
I think we can't really have a definite guideline. It has to depend on multiple factors. One is, how is the patient? What's the age? Are there comorbid conditions? For example, a patient 75-year-old come and on incidental finding you have a 2 centimeter lesion in the pancreas. What are the comorbid conditions? So I'll do the first imaging I'll see whether it is benign looking, and I can ask the patient to come back 3 years later for another surveillance. On the other hand, you have a 45 or a 50-year-old lady has a 3 centimeter lesion, otherwise well, I would say she will probably require surgery in some period of time. There your frequency of surveillance may be earlier. So first imaging you do today, everything is okay, call after 3 years, everything is fine, you find how the size of the lesion is increasing. If it is very slow or not increasing, 5 years later. So I think it has to be individualized. You can have 1 year, 3 years, 5 years, but can't be having definite guidelines.
Sir, my question is regarding US, and you mentioned plus minus FNA, but quite often the observation is that there is a solid lesion which is imminently resectable, maybe more than 3 centimeter. US has been done, and then an FNA has also been done, and then the relative would invariably say, sir, wo report to biopsy report to negative.
I wouldn't do FNA. I would go for surgery. If the patient is operable, lesion resectable, take it out. Physicians have to think like surgeons.
Sir, I will like to add, actually it was very vast topic you were given. It was not easy to cover all the different kinds of lesions, and there are different guidelines, completely different for different kind of lesions, solid, cystic as well. So I will just like to make few points here. In the cystic, regarding the cystic neoplasm, you have generalized most on the basis of the size of the lesion. I will strongly differ there from the surgeon point of view and based on the current recommendations. Mucinous neoplasm, you mentioned less than 3 centimeter, wait and watch. I will strongly differ. Current guidelines say mucinous neoplasms have significant neoplastic potential. So in all cases, whenever the patient is fit for surgery and mucinous neoplasm we are suspecting, we will go for surgery. The type of surgery and the extent of surgery will differ, and the location of the tumor. If there is a young patient and mucinous neoplasm even less than 3 centimeter in the tail of pancreas, I will go for a simple resection. I may not remove the spleen and the lymph nodes along with that. Same patient, 4 centimeter tumor, I will do pancreaticosplenectomy, distal pancreaticosplenectomy. Wait and watch approach no longer stays correct for mucinous neoplasms. That is only for serous neoplasm nowadays. And there too, we have to watch the increase in the size. More than 5 mm per year is indication for surgery. And one more point I will like to make. Initially in the slides you mentioned PET scan. So I will differ there again. In pancreatic SOLs, PET CT is no longer recommended first line of imaging. It is the kind of last resort. Always we have to start with triple phase CT scan for any pancreatic lesion. And that triple phase is different from what triple phase we do for liver. Pancreatic protocol triple phase is entirely different, and that is the most commonly missed thing which we see in the clinical practice. Many patients come from CT done outside, they say it is a triple phase scan, we don't see any tumor, we wait and watch, later they come with recurrence. The problem there is the routine triple phase scan is taken in arterial, venous and delayed venous phase, but for pancreatic tumors we need delayed arterial phase, which is Pancreas protocol. So any pancreatic SOL, which were incidental tumor which we are talking about, incidental tumors are those tumors which are missed in routine CTs. But if that patient has undergone a specific Pancreas protocol CT, that tumor would not have been missed. So that will come under the ideal incidental pancreatic tumor. So that I will like to add.
So this time will not be counted in my time. So I don't differ with him, I'll send my patients to him.
It's a great talk, sir. I have a small question. So if patients are symptomatic and have a main duct IPML, they are symptomatic with pain or recurrent acute pancreatitis, and you find these lesions, and they fit into 2.5-3 centimeter cyst with 8 mm MPD in the head, but the distal MPD is not dilated, and there is no evidence of chronic pancreatitis. So would you just go for a surveillance, or would you just say go ahead and get this?
So if I understand correctly, you're saying there is a lesion in the head. The duct is dilated, not distally.
Not distally.
So it's kind of a mixed time, or
correct.
I would say that patient is operable. My preference would be surgery.
Surgery.
Yeah.
Thank you, sir.
Rajesh.
Last question. So, cystic lesion, we always correct in absence of, because we commonly see cystic lesion in US. If there is a cystic lesion in absence of history of pancreatitis or previous imaging generally is not available, would you recommend aspiration in those patients, because that the characteristic of the fluid determines whether there is mucinous or non-mucinous cyst.
If my decision is not to operate, I probably won't put in a needle. I would follow up. If for some reason I think this patient should undergo surgery, then I will put in a needle.
Younger patient?
Well, that's what I'm saying. So overall patient's condition is such that I want to operate, right? I'll put a needle if I'm not sure. Otherwise I will wait. I'll just follow up.
Thank you, sir, for such an interactive talk on pancreatic SOL. For further queries, you can obviously meet sir during the lunch period. I will request the sir and chairpersons to join at the center of the stage for the photograph.